program is the first in a series of 3 webinars that are focused on the intersection of mass vaccination and infection prevention control. Before we go too far, I'd like to go ahead and offer an acknowledgement to CDC for the funding for this project. Funding for this opportunity has been provided to the National Network of Public Health Institutes through a cooperative agreement with CDC. NNPHI is collaborating with CDC's National Center for Emerging and Zoonotic Infectious Diseases, Division of Healthcare Quality Promotion on this project. Contents of this RFP are solely the responsibility of NNPHI and do not necessarily represent the official views of CDC or the US Department of Health and Human Services. So as vaccine rollout began, pre-COVID-19 and early mass-based vaccination plans anticipating the vaccine rollout relied heavily on leveraging existing community-based healthcare sites to administer vaccines. So we think about clinics and pharmacies and local government public health physicians. But we know that the use of conventional healthcare sites is not sufficient to achieve rapid enough vaccination to stop the pandemic. A hybrid approach using conventional vaccination sites, along with high throughput, large venue mass vaccination sites, including stadiums, arenas, convention centers. These have proven essential now and in the years past, Simply put, while traditional infection prevention and control has roots in healthcare and clinical settings, given today's response mechanisms to the pandemic, these protocols are being pushed into other spaces, alternative spaces, with more focus than ever. These rapid changes, including more than 300 just-in-time trainings that we've seen that have been created and published on various widely circulated training sites since the beginning of the pandemic. These rapid changes and this influx of information can prove overwhelming and even distracting to public health and emergency management officials as they try to plan for and integrate basic infection control principles and risk reduction principles into their response activities. So that really is the focus of today's program. So let me go ahead and introduce our speakers. Our first speaker of the day is Summer Burton. Summer is in her last semester of the master's program at Tulane, and she's in the Department of Global Community Health. She is also getting a certificate in disaster management and resilience. Summer has worked with Via Link, a nonprofit organization which runs the Greater New Orleans 211 system to create social determinants of health dashboards, and also with the New Orleans Office of Homeland Security. Summer has a professional interest in infectious disease outbreak response. Specifically, she is interested in how to strengthen preparedness response efforts to mitigate outbreaks. Today, Summer is going to talk with us about infection control trainings and resources that she found in her environmental scan work. Our second and featured speaker will be Dr. Jeffrey Elder. Dr. Elder is a clinical associate professor of medicine in the section of emergency medicine at LSU Health Sciences Center in New Orleans. And he also serves as the co-director of the Division of EMS and Disaster Medicine. He's the medical director for the emergency management at the University Medical Center and LCMC Health. He's board certified in both emergency medicine with subspecialty board certification in emergency medical services by the American Board of Emergency Medicine. Today, Dr. Elder is going to talk with us about mass vaccination operational infection control. And with that, Summer, I will stop sharing my slides and allow you to share yours.
Thank you, Montrese. One moment. All right, just like Montrese said, today I'm going to be talking about an environmental scan of the infection prevention and control trainings that I have found as a graduate research assistant with Project First Line. So just an overview of the agenda for today. We're going to first speak about Project First Line's objective in the infection prevention and control sphere, and then talk about the specific project and scope of work that I have been involved in. Second, we're going to talk about the scan that I have done and include the process, the sources, the initial trends and findings of the scan, as well as the next steps for our team. Project First Line was created as a collaborative among multiple national agencies and institutions with an overall objective to build infection control training expertise within the public health workforce to support a culture of infection control in healthcare communities everywhere. Their focus is both in healthcare facilities as well as public health agencies who work at the individual and community levels. The project that I am involved in as a graduate research assistant is based on the question, what is out there in terms of infection prevention and control trainings? What is out there to help healthcare workers, public health professionals, and the general public protect themselves and others from infection of COVID-19? Thus, my scope of work in specific terms is to conduct a scan for existing public health and environmental health professional credentialing programs, review the existing programs for opportunities to incorporate infection prevention and control content, and later potentially work with those credentialing organizations to add IPC content. All right, so the environmental scan process. First, the team was tasked with developing a list of keywords that were relevant to IPC. Naturally, the first keywords that came up were infection prevention and control, epidemiology, personal protective equipment or PPE, phrases that were sure to include information that we were interested in. A simple search of COVID-19 or novel coronavirus was obviously also utilized to uncover some of these trainings. Second, the team held discussions surrounding the potential peripheral aspects of IPC. Surely we were going to talk about vaccinations for COVID-19, which is an incredibly relevant topic, especially lately. Early conversations about the cold chain storage with dry ice were occurring, but were trainings or general information actually available on dry ice? These were kind of the questions that we were asking ourselves as we went along. What about ventilation or other industrial hygienic pieces that may aid IPC in places such as businesses, schools, even hospitals? It has been established that not all HVAC systems are able to function with the required filters to help remove COVID particles from the air. But is this information that is available for business owners who may need to incorporate these air filtration systems for safe reopening? These engineering and industrial hygienic aspects are definitely more towards the periphery when we're talking about infection prevention and control strategies, but are still absolutely relevant and useful for our purposes. And lastly, it was important for us to identify the relevant sources that may house some of these trainings. So going more towards into these sources, at this point of the pandemic, it's pretty safe to say that most organizations and institutions who deal with health in any capacity have developed or instituted or promoted some level of IPC training. When we think about infection prevention and control, quite a few prominent organizations such as the CDC, the WHO, or academic institutions such as Johns Hopkins come to mind. These organizations are likely to have a wide range and large amount of useful and reputable trainings. Luckily, the Public Health Foundation created a website called Train, which is essentially a mecca of trainings from all of these various organizations and even smaller, less prominent organizations. We were also very fortunate to have a member of our team who helps run the Region 6 Public Health Training Center, who was able to reach out to the other 9 regions to request their trainings that were relevant to IPC. And lastly, it was important to step out of the traditional health and public health contexts to see what is out there for various businesses and workplaces that may encompass IPC. This looked like national organizations for beauty salons, restaurants, the hospitality industry, schools, even summer camps had developed trainings and guidelines to prevent and control the spread of COVID. Also, transportation services was an important avenue to explore, such as maritime organizations for commercial boating, cruise ships, things like that, trains, border crossing, etc. There's a wide range of specific IPC trainings out there that we wanted to try to identify. I included this list just to give you an idea as to how many developers played a role in the creation of COVID-19 and IPC trainings. Looking at this, we can get an appreciation for what is out there. Did all of these trainings reach a good amount of people? Are they outdated in terms of recommendations and guidelines? Do they include information that is truly helpful for the audience they are targeting? And some of these names are going to be very familiar to you, such as the WHO and the CDC, but there are also some that are pretty more innocuous, some that I had never heard of, such as the American Waterways Operators or the Professional Beauty Association, who developed IPC trainings for salons and barbershops upon reopening. And the CDC obviously has an abundance of agencies under its umbrella, so it is important to mention some of the important affiliations there, such as the Advisory Committee on Immunization Practices, the National Center for Emerging and Zoonotic Infectious Diseases, as Montree said a little bit earlier. Those types of agencies also definitely played a role in these trainings. So now we can talk about the interesting stuff. The IPC scan analysis that we identified. I input a spreadsheet with relevant details such as the name of the training, the developer, the type of training, the training's target audience, and a brief description. All of this was kind of done with the ultimate vision of giving us the ability to identify quality trainings based off of a number of different factors. If we wanted to focus on a target audience of the general public, we could have those types of trainings that we have found, or if we wanted to focus on long-term care facilities, we can then focus on those. Or if we wanted to focus on those larger, more reputable organizations where we can have some confidence in knowing that they have high quality content, we can choose that avenue. So just putting it out in a way that we can do a lot as a team. So on to the initial trends and findings. What did I find while doing my initial scan of the environment? There seem to be two distinct groupings for these trainings in terms of length. A good majority of these trainings that were quickly put out, as Montree said earlier, due to the fast pace of information dissemination and development that we were going through early last year, they were created and put out in short bursts as we figured it out. So short trainings, webinar based. I'm sure many of you have attended a lunch hour webinar for COVID over the past year. They also came in the form of guidance documents and infographics, such as the quick IPC 2-pagers for businesses who are reopening, or how to properly don and doff PPE, items of that nature. It is important to note here the idea of the fast moving pace that information was coming to light early in the pandemic, even now to this day, but less so for IPC. However, these quick and easy to digest trainings, especially from those early months in 2020, may be outdated in terms of the IPC recommendations that are utilized today. This is an important part that will be at the forefront of our minds as we move on to the analysis phase of really getting into the nitty-gritty of what these trainings hold. So just asking ourselves how relevant the data is to what we currently know. And second, there are longer module-based trainings that are more dense with information. These are often created with large organizations such as the CDC or agencies under the CDC umbrella, or the WHO, who have the capacity and the bandwidth to create these intensive trainings. A point to note here is that many of these trainings may have been created prior to the COVID pandemic and encompass information that falls within the broader IPC spectrum, such as general hand washing, or the different types of precautions one can take, such as contact versus airborne precautions in a clinical setting. But many were adapted to incorporate COVID-19 specific IPC practices. So next we're going to talk about the common focal points that I uncovered while conducting the environmental scan. Many trainings were identified that covered vaccinations, personal protective equipment, case investigation, long-term healthcare facilities, and safe reopening. So almost 50 trainings have been identified for mass vaccination, most with a strict focus on the COVID-19 vaccine rollout. A small subset of trainings were on two specific COVID-19 vaccination types, the Pfizer and the Moderna, less so on the other types such as Johnson & Johnson, AstraZeneca, ones of that nature. Many of these trainings held information on the storage and handling of the vaccine itself, which fell under that periphery aspect of the scan that we talked about earlier. And many more also talked about the vaccine administration and waste management of the needles, all which have a very important basis in infection prevention and control. Dr. Elder is going to talk a little bit about that later, so I won't go too into that, but some other trainings also had a focus on VAMS, which is the Vaccine Administration Management System. And another common focus, which is most likely no surprise to anyone, is guidance trainings and more about personal protective equipment. PPE was in most trainings across the board, and target audiences ranged from healthcare providers, EMS and law enforcement, public health professionals, and the general public. Some types of information in these trainings were ideas such as how to properly don and doff masks, gloves, other respiratory equipment that was being utilized at the time. We remember at the height of the pandemic when it was common to reuse face masks such as N95s, still relevant in many parts of the US. So reuse guidelines are apparent and available, specifically in healthcare settings. Also related to this is the idea of disinfection of PPE that is being reused. This included the thought of UV light as a mechanism to sanitize face masks. And there's a large range of information out there on how to properly do that and how to implement that in your business or healthcare facility, whatever it may be. So case investigation is also a prominent category of trainings. This includes ideas such as contact tracing and surveillance that was also overwhelmed during the height of the pandemic. And these trainings really encompassed all potential levels of these mechanisms. First, there are trainings for those at the decision-making tables, the public health professionals and the emergency managers who may not have been exposed to what contact tracing or surveillance truly is. The objective of the trainings here were to give them a basic understanding, not only on what it is, but how they can ramp up the contact tracing efforts. Second, trainings for contact tracing managers who will be tasked with training the contact tracers. Objectives here are to increase the effectiveness of the contact tracing and identifying suspected or exposed persons. And lastly, there was just-in-time training, the quick-based trainings for contact tracers who were going to be hitting the ground running in this aspect. There's also a strong focus on long-term care facilities. We now know that these types of facilities, such as skilled nursing facilities, assisted living facilities, and nursing homes, were at increased risk of outbreaks of COVID-19. An interesting difference here is the shared communal area aspect, including the activity rooms, the shared laundry services, the mass-producing cafeterias with shared utensils, things like that. This produced more specific trainings for sanitation and disinfection of shared materials to eliminate fomites and transmission of the virus. Recently, incidence has actually been reduced in long-term care facilities, but it is still incredibly important to maintain vigilance in IPC practices for resilience and resistance against further infections. And lastly, we found many IPC trainings covering the many different aspects of everyday life in regards to safe reopening. This included general workplaces as well as customer-facing workplaces. As stated earlier in the sources piece, we really had a far-reaching scan that included trainings for restaurants to beauty salons to cruise ships. An interesting finding here is that the content of these trainings or guidelines tied together many different aspects of IPC that we have been talking about today. So they would include things such as how to conduct small-scale contact tracing if an employee were to fall ill with COVID, basic infection prevention techniques such as sanitation, disinfection, or social distancing. Many even included the proper chemicals to use when sanitizing or disinfecting different areas, such as shared kitchen spaces versus desks and computers. Lastly, bringing back into the periphery aspects, ventilation trainings ratified more so in an industrial hygiene context. So whether to use HEPA filters or MERV 13 filters in your workplace to help remove some of that stuff from the air. So where do we go from here? The next steps of the project are moving to an analysis phase of the hundreds of trainings that we have identified. So the goals here are to both identify quality trainings as well as identify any gaps that may be present in the trainings. Are there high quality trainings that we can promote? Naturally, we are reaching a time where things are opening back up, but we still want to keep people safe and aware of IPC as we transition back to normal. Are there areas of these trainings that are sparse, and do we need to create guidance for some specific area that would benefit immensely from a guideline or a training? We're all pretty excited to get to this next phase of the environmental scan to truly see what we uncover past this initial scan findings that I just talked about. And with that, I thank you all for taking the time to be with us today. I look forward to hearing from Dr. Elder about the vaccination efforts in New Orleans. So I will stop sharing my screen and give you the floor, Dr. Elder.
Thank you, Summer. I appreciate it.
Of course.
And Dr. Elder, while you're getting your slides up, I just want to remind our attendees that if they have questions, they can go ahead and use the chat box and type those in. We'll be doing Q&A toward the end after both of our speakers have given their remarks.
All right. Are you guys seeing it? Seeing the screen now? I'm sorry, I lost it.
You can see your screen.
Perfect.
Yep.
Yeah, slides. Thanks. All right. So I'm going to talk today a little bit about the operations of what we did at the Memorial Convention Center. So LCMC Health started a program called Getting That Number, which is a mass vaccination kind of just push to get as many people in our community vaccinated as possible. We opened this in early March of this year, once vaccines really became available to have a much larger site to push more vaccines out in the community. And the goal here was to go and push forth with, about 3,000 plus vaccines a day at one singular community site. And so as you can see here, it was all about space, and more space. So we know that we needed a large space to allow for distancing while also being kind of efficient in our staffing and how we moved people through, this community site. And so the Memorial Convention Center for us and throughout my career has actually been a site where we've done large scale healthcare operations in the city of New Orleans multiple times. I'm sure many people have heard about what happened there for Katrina and the fact that we, had a bunch of evacuees that unfortunately were there during that event. But, since then, we've utilized the convention center for healthcare in other ways. So we've utilized it as shelters during hurricanes. And we actually, just before setting up this mass vaccination site, had shut down a medical monitoring station for COVID that was set up in the summer of 2020 when our numbers really were raging, in Louisiana and specifically in the New Orleans area. And so, we know we needed a large site. We needed a site with HVAC and the ability to move a lot of air. And so this is a very large room. So if you see here, this is what we call Hall J in the convention center. It is, 90,000 plus square feet of space. And we have, just a very large area to be able to get a lot of people in without, having the crowding that can occur, while also having the air exchange to move, a high volume of cubic square feet of air in and out the building. And this was initially looked at for the medical monitoring station, because just next door to where we were initially was an area where we could support hundreds of COVID patients. And of course, that was a big, concern for the convention center initially to say, hey, can we do this safely? And we had already been through all that with the medical monitoring station setup. And so we knew that we could move enough air through to really keep this place safe for those that would be coming in and out for their vaccines. And ultimately, we wanted people to feel safe coming into this large area. For a lot of people that we talk to as they come into the convention center for the vaccine, they really hadn't been around others. They had really taken the advice of the public health officials and the governor and the mayor of New Orleans to not have gatherings, and really they were home. And for some of these people, this was one of their first outings in over a year. And so we wanted people to really feel that they were safe. And we didn't want any, additional anxiety for going out into an area to get vaccinated, but yet have to be around a bunch of other people in close proximity, which of course, would be an infection control nightmare. And we had seen some of this in some of the mass testing sites previously. And so we knew this was a concern, and we just wanted to kind of make sure that people felt really comfortable as they went through. As you can see here, being a large, site, we needed to be able to keep people through with continuous movement. And so one of our goals here was to avoid congregating in lines. And so we had plenty of space. We had plenty of people, so volunteers to help move people through. And we had signage everywhere. So you can see here, floor decals, large numbers next to the tables for registration and check-in, and staff there that were directing patients throughout the entire process. And as we move on, this is the entrance area. So these were the queuing lines that we utilized as people walked right into the convention center. And so, everything kind of started here. So we had signage, we had stickers on the floor, again, all to keep that distancing. When you walked in, you were greeted by a volunteer who, kind of went through the quick COVID symptom screening questions with everyone that came in. We had translators on site, both Spanish and Vietnamese in person, that helped to kind of quickly, screen people if they didn't have a mask for some reason. And we had, plenty of signage about masking. We had masks that were available there. And so we really tried to catch everybody as soon as they got into the building and make sure that they were screened, they were masked, and then that they continued to stay away from other people as appropriate with social distancing. And this continued throughout the facility, from the entry to the queuing lines, to check-in and registration, to vaccination, and then ultimately all the way over to post-vaccination observation. And so, I guess the first thing we get into are, surfaces. So some of our major touch points. And so probably the biggest touch point is just getting into the building, right? So that's the front doors, which we continued to disinfect throughout the day. Our other major touch point are these kiosks for our check-in. And so in order to keep people moving, we really pushed to have registration done offsite via either phone calls and phone registration and or on the web. And we could have people really put all their information in on the web, be fully registered. They would bring a little QR code that they would bring in at these check-in stations. They would then scan that code that would check them in, and they would move on to their next to the next open available seat for the vaccine. But there were some touch points here. So they had to use the tablet. We kind of set this up much like you would see in an airport when you check in, when you do the self check-in. We wanted to be, quick and easy. But we knew we would have to kind of keep people moving. So we had it staffed appropriately, where we had workers through patient access that were there who could help people through the process. And then once they left that area, they could then disinfect the table and the screen. And so we'd have wipe downs, in between each person. And this really proved to us to be very quick, very efficient. It allowed us to keep people moving. And we had plenty of stations. We had about 40 stations at a time. People could be checking themselves in and then move on. And of course, sharps. So this is a huge infection control issue for our own employees, mostly. As healthcare providers, we deal with this all the time. I'm an emergency physician by training, so we see needle sticks all the time. We see them, through the healthcare providers. We also see them, as the ones taking care of people who maybe had the needle stick. And so this was a big deal for us. So, to start off, we've done 50,000 injections roughly in this area, and we've had 2 needle sticks. Both were unfortunate, but I think overall it's a relatively low number for the amount of vaccines that we're pushing through and the amount of intramuscular injections that we're giving. And so here, the biggest thing I think is, using the safety needles, right? And so interestingly enough, when we received shipments of vaccine, there were 2 different safety needles. Typically with Pfizer, we received the Vantage Point, where you would actually inject and then push on the plunger a little bit and the needle would retract. These are great. These are some of the best Vantage Point needles I've used in my career. And then we also had with Moderna some of the hinged arm shields that you just have to flip over. Of course, we had to make sure we had plenty of sharps containers. We wanted them easily available. So at each station, we had multiple sharps containers. And just to make it easy, because we were going through such a high volume of people, we just wanted to do this quick and make it painless and get people out. And then, so the nurses were working pretty fast at a comfortable pace. And so we wanted to make sure that they could easily, discard sharps without any problems. And of course, we then, would have our usual process for, collection of the sharps containers and then the ultimate, disposal as we would at any of our other healthcare facilities. And we set that up through our contracted vendor to do that. One thing that we did have to set up and we had to kind of augment during the process was a process for, needle stick injuries, because we've had 2. And so, during our first needle stick injury, we had all the paperwork, we were ready to go, we knew what to do with it. And so we really followed just like we would at any of our hospital-based clinics. And really this mass vaccination site functioned as a off-site clinic of one of our hospitals. And so we were able to get the information, we were able to send the employee to have proper testing done. But the question really came up about the source patient, because we're used to just drawing blood from the source patient wherever they are. And that wasn't something we were really set up to do. So luckily with this first needle stick, the source patient was extremely nice. They went to the emergency department and were able to give blood. And we walked through the usual kind of needle stick practices that we do in the evaluation. But then we were ready when we had the second needle stick that we knew we had to bring not only the paperwork and all the documentation, but even just the equipment to draw blood from the source patient on site. And so that really guaranteed that we'd be able to get source patient blood and be able to go through the full evaluation for the employee who was stuck, to really give them good information on, post-exposure prophylaxis and the medications they may need to take and just their overall risk. As we have very quick, rapid HIV and hepatitis testing, we're able to do that at the hospital. And so I think that was a really good process that we followed throughout our system here. And we're able to just expand that to this, offsite location. And finally, I think the biggest thing here are our people. We, during this process, knew that we were going to have to bring in lots of people. We brought in contract workers, part-time workers. We brought in nurses from our hospitals and clinics. And additionally, we worked with some vendors to bring in some additional staffing. And this really was a mix of vaccinators. So in Louisiana, we have a large pool of people we can utilize to vaccinate, which has been extremely helpful. That's anywhere from RNs to LPNs to medical assistants to paramedics and EMTs. And so for most RNs, LPNs, and paramedics, given intramuscular injections are something they do all the time, they're very used to it. For a lot of our MAs, while it's typically within their scope of practice, they just weren't doing that often in their clinics because they had nurses that they work with that often did that. And so there was a little bit of an education piece there that we had to perform. And for our EMTs, the ability to give intramuscular medications was an emergency power granted through our EMS licensing commission to give us a larger pool of vaccinators in the state. And so for that group, they had to go through special training, be checked off, and get used to administering these intramuscular injections. And so for really our MAs and our EMTs, we had to do a little bit of extra training, but really just make them feel comfortable with this procedure that they typically, don't do every day. And we made that a part of their orientation. And I think the key here to remember too is, this is a large operation, but really, slow and steady kind of wins here, right? So if we can get people through efficiently, keep them distance, we had them set apart at least 6 feet on the floor with each chair as they got vaccinated in small groups of 3. That would keep a little bit of a pod together for the nurses and the vaccinators. We would then move them to an additional area for post-vaccination monitoring. Again, 6 feet apart with chairs. It was a very large area, so that allowed us to do that. And then also here, you can see in the picture, our PPE with masks and gloves. Obviously, as healthcare providers, we stay masked all the time while we're at work, especially around patients. And then, we had gloves available. They would change in between each patient. We have hand sanitizer stations that were at each location, so they could sanitize their hands in between each patient. And that's just, part of the process. And so, our employees just continue to do that. Moving forward, the mass vaccination sites across the country really are starting to slow down. We're starting to shut down, at many different sites. We're looking at how we're going to wind this site down. But in reality, we're really just going to switch over, and our manpower will move to some of the mobile vaccination things that need to be done. And so we know that we're going to have to go into smaller pockets of the community, to neighborhoods, to churches, to schools, to residential buildings. And we're going to have to really work hard now to get those people who maybe have a little bit of vaccine hesitancy, or just, have questions about vaccines. And so when we first opened this large mass vaccination site, it was all about how do we safely do this in, a large venue with thousands of people a day coming through. And we're at the point now where those masses of people who really, were very anxious to be vaccinated have been vaccinated. And the people that were kind of on the edge are starting to come in. And we still have plenty of people who need to be vaccinated. Over 60+% of our population still needs to complete their series in Louisiana. And we're going to continue to see people, but now we're going to have to transition the things we learned at this mass vaccination site to the much smaller venues, whether it be a church or a community event, or here in Louisiana we have a lot of festivals. And so as we start to have some of the outdoor activities, have, people there that are also vaccinating. We've seen in New Orleans Shots for Shots, where they've gone out to bars and they've vaccinated people, at night when they're out at the bar, because it's a captive audience. You have them there and you can get them vaccinated. So I think we're going to be utilizing all of that to get more people vaccinated. And we're going to take the things that we learned, from this process as we scale it down and then make it mobile. There's no reason why we can't use the exact same processes that we've used at this large venue to some of these, smaller locations. So that ends it from my portion. I'm going to try to stop sharing my screen. If you guys have any questions, I'll get my contact information out there, but happy to, answer any questions as we go through.
Montrese, you're on mute.
Thank you so much, Dr. Elder, and thank you, Summer, for both of your presentations. We're going to go ahead and dive into the Q&A portion of our program. And our first question that we have is for Summer. And as I lean into that question, again, please be reminded that you can use the chat box to offer your questions for our presenters. So Summer, one of the questions that we got was related to how much these trainings were costing as you found them in the environmental scan. Like I think all the trainings in Train are free, but was there a cost associated with the trainings that you found in the scan?
Actually, Train does have a little snippet that are not free. They have some that are costly, but it'll bring you to the site and show you all of that information. I would say the vast majority of the trainings are free that are a part of our scan, but we did incorporate a little snippet, a little paywall trainings section of our scan to incorporate some of those that are costly. A lot of the ones are more geared towards the businesses and the general workplaces. I don't want to name names, but some in like the hospitality industry, they'll have like a members only section of trainings, which will be for like the business owners to take in. So they're still relevant. And we may still delve into them, maybe reach out to those organizations and agencies to see if we can get a cost reduction on looking at what they actually have in their
Get
trainings.
behind that paywall.
Yeah, get behind that paywall. But as of now, they're available. We just have them in a separate section. It's a very small subset of the trainings that we did find, though.
And on that same note, Summer, what's the dissemination plan around your findings? Do you know? Do you guys have a plan to disseminate the findings?
I'm actually not sure that we've gotten that far yet. I think we're still in the early phases of the analysis and just seeing what we have. I think the goal is to create kind of like a 1 or 2 pager with quality trainings or gaps that we've identified and seeing what we want to do when we have that information available to us.
Thank you for that, Summer. Dr. Elder, one of the questions that we have for you is really an overarching question. And that's, you know, when we think about infection prevention control in mass settings, what's the biggest infection control problem that you're seeing?
Yeah, you know, I think we did a really good job as far as, you know, the safety of everyone from COVID. And so that was obviously our biggest, you know, fear going into this was how do we bring a lot of people into one area, which is why we use this very large convention center site, which luckily for us had been used for healthcare, you know, purposes, you know, many times before. And so that was really the biggest fear for us. You know, we saw that people were very comfortable walking through. You know, everyone stayed masked. It was actually almost a festive atmosphere at times because people were just happy to be vaccinated. And as an emergency physician, no one ever wants to see me as their doctor because they've always had a bad day because they're in the ER. And so it was really nice for all of the staff there to see people who were just so excited to be there. And I feel like that was our biggest challenge. We did a really good job at that of keeping people separated and just, you know, feeling very comfortable in that area. But it was very intentional. And so it took a lot of work to get there. You know, ultimately, you know, our biggest risk has been the needle sticks. You know, we had 2 incidents, unfortunately, but they were really the biggest infection control issues that we've had to deal with. You know, luckily everything worked out. It all went very smoothly. But I think that's been our biggest thing. And again, just because we have such a large volume of people coming through, you know, there's a lot of needles being used at each table. And I can tell you those little Vantage Point syringes are worth their weight in gold. They've been tough to get actually across, you know, logistics chains across the country because of all the vaccines that have been going forward. But luckily now as we, you know, especially with the Pfizer vaccine, because we had that kind of magical 6th dose, and initially you weren't getting all the syringes for all of your doses because of that. Now the federal government has changed some of their logistics operations with the delivery of the vaccine where you will get that 6th syringe as well. So we don't have to really go out searching for syringes and going through all the, you know, the nightmares of the logistical challenges of getting some of these supplies, which are really in short supply. And so that's really helped us out tremendously.
That raises another question for me that's similar to the question that we've seen come in. It's the question around, you talked about needle sticks. How are employee exposures handled in a mass, in a stadium, in an arena versus in a medical facility, in a traditional healthcare facility?
Yeah, I think for us, we were lucky that we were close to our kind of mothership hospital, which is University Medical Center. And so for us, we were able to really take that same process that we use at the hospital, translate it to, you know, this massive clinic by bringing in the ability to take source patient blood on site, that allowed us to, interview the source patient, get their relevant information, get their blood sample, and then just take that with the employee down to the emergency department over at University Medical Center and go through our typical process. And so, as a lot of us know by process, when you change is when you're going to have problems, because you have to do a lot of education and there's a lot to deal with. So for us, we followed the same process, and that really worked very well for us. We were able to put people through our rapid treatment area in the emergency department, just as if we would if they had been stuck or had a needle stick injury in the hospital. So it was the exact same process. So I think that worked really well for us.
Thank you for that, Dr. Elder.
Sure.
Summer, when we think about your environmental scan, there were over 300 trainings that you found, and you could have kept going on and on and on. I'm curious about, from your perspective, having done this work, what was missing? What gaps did you identify in this work?
I think one of the things that we were missing, and I think this points to Dr. Elder's points about that education piece, is the just-in-time trainings that are done real time right before you engage in vaccine administration. I know in New Orleans, there's a lot of in-person trainings that are happening on certain aspects, such as vaccine administration, or in the workplace, trainings on how to do this disinfection. And we're missing a lot of what is actually occurring in real time at that just-in-time level. And we know it occurs, but with this scan, we can't quantify it. We can't analyze it for quality. We can't identify misgivings or issues with those just-in-time trainings, which I think is, it's unfortunate that we can't see those in real time for our purposes.
Yeah, but I definitely think that's worth capturing as a lesson learned in this process, because that's a key part of doing this work and doing these webinars is to spread the lessons that we're learning so that we can make changes as we move forward.
Absolutely, making it more accessible.
For sure. Dr. Elder, there's a question specifically about a slide. You've got a slide on LCMC, and it shows a pink label wrapped around the syringe. What is the information on the label? I guess the question should be, is it relevant? And then what is the information on the label?
Yeah, I think it is relevant. Everybody learns when you drop medication, you have to label it, right? And so no different with our vaccines, even though we had typically, one medication a day that we were using, one vaccine each day. And so what we actually did, our pharmacy team actually color-coded the labels based on what vaccine we were giving that day. Because, initially when we first opened, especially, we didn't know up until that week which vaccines we would have available. And ultimately, we've given 3 different vaccines at this site. So Pfizer, Moderna, and Johnson & Johnson. And so it's just important that we know that we're giving people the right vaccine. And so one of the things we did is when we label the vaccines, each vaccine has its own color. And so it's just one more way that people ensure that, not only is the label right, it's labeled, Pfizer, Moderna, Johnson & Johnson. We also put the lot number on it, and then the expiration, because as we open up these vials, typically we would have about 6 hours, depending upon which vaccine, to then get that injection into a patient. And so that just allowed us to help monitor our vaccine stock as we were going through the day to make sure we were utilizing the vaccine appropriately. And so that was just one of our little color-coded tabs that just kind of kept us in check with what we were doing each day.
Thank you for that. Great question. We talked a little bit about the differences in using alternative care sites for mass vaccinations, but are there specific shortcomings to providing vaccinations at a non-healthcare facility, Dr. Elder? Like, are there identified gaps or issues that come up because we're not in a healthcare facility providing these mass
Yeah,
vaccinations?
you know, I think one of the biggest things that we initially looked at too, and this came into play of why we picked the convention center's location. You know, can people get there easily? You know, a lot of people in our community who are reliant on, public transportation, they don't have a vehicle. You know, can they get there? And for a lot of our patients, getting to the hospital is easy because we have that built in already. They know how to get there. They can, take the bus. They can get off at a stop that's right by or right in front of the hospital, and they're there. That didn't really necessarily exist for, all of the convention center. It's a very large building. It's over a mile long, just if you walk across the front of it, because it runs the length of the river in downtown New Orleans. And so we had to make sure that we had the correct space. We worked with, our public transit system to make sure they had drop-off points. We also worked with Uber, who had free rides, so we could drop people off, at the location. And we actually did that at all of our hospitals where we were doing vaccinations, which was extremely helpful. And we just wanted to make it a site that was easily accessible to everyone, and then including parking. So the site in the convention center that we utilized was directly across the street from a large parking lot. And so we made that very accessible so people could drive up, get in and get out. And really, we became so efficient in this location that, we would get people in and out in under 25 minutes. And so that included 15 minutes of, shot time, just sitting there waiting after your vaccine. So within about 10 minutes or less, we could get people in, registered, vaccinated, and then get them right back out the door.
Thank you for that, Dr. Elder. There are questions coming in fast and furious. I want to make sure that I circle back to the color-coded labels before I turn the corner. Are these universal, these color-coded labels? Are you going to find the pink ones in all health systems? Like how does that?
No, that was just something we did. So that was something our pharmacy did. And so for us at this location, because we're using multiple vaccines, we made sure that we stuck with that process. So, we stayed with the singular colors. But I'm sure it's different, at other places.
Kind of curious to see how other jurisdictions are doing that. There's a specific question that I kind of want to turn to both of you on. It's a question around UV sanitation. Let me find the question. Let's see. So UV disinfection and other chemical disinfection or sanitation. So I'm just kind of curious, first of all, Summer, did you see any trainings that were focused specifically on that? The question is just really a broad question around, thoughts on UV disinfection and other chemical disinfection or sanitation. So I'll throw it to you, Summer, to see if you saw any trainings that were related to that, and then we'll talk to Dr. Elder and see what his thoughts are on that.
Yeah, it's kind of a newer thing of using UV light to truly disinfect a lot of different things, especially in the context of COVID. I think what's really interesting is how UV light disinfection can be what happens when that is used with other chemicals used for disinfection purposes. And I think that deep-rooted question is kind of less so seen in the trainings, but what we do see and what is really important is the proper use of chemicals and other disinfectants in common places and the proper PPE that should be utilized when using these types of chemicals. When we think of like the off-gassing and the potential for harm if you're not using proper PPE, those types of ideas. So I think there are a lot of trainings surrounding how to protect yourself when using proper chemicals for disinfecting purposes, but less so on UV-based light. There's some guidance on how to use UV light to properly disinfect your things, but I think it's kind of still a newer topic. I don't know,
Yeah.
Dr. Elder. Yeah, go ahead.
Yeah, I'll just add that, at the convention center site, we did not use UV light just just because of the size. I mean, it would be kind of practically very difficult to do that. I can tell you on the hospital end, we did utilize it heavily, especially during the initial COVID kind of push that we had in the New Orleans area in March and April of 2020. Our hospital actually utilized some of the UV light cleaning systems prior to COVID. And once we started to see, our big push of patients, and remember, New Orleans was one of the areas hit hard early. And so in March of 2020, we really, had our big push of patients. It was just after Mardi Gras, where we had a lot of people in town. That probably is what, set off our big, numbers of COVID in our community, because we had so many people around each other in large groups and everything just at the wrong time. And that pushed into April. And so we did utilize UV light. It became part of our typical and routine cleaning process for all of our rooms where we had COVID patients. So, we have a process where, a COVID patient was in a room. Once they were out the room, you had to wait about 60 minutes. That would allow everything to settle in the room. We could do our usual cleaning, and then we would come in with our UV light cleaning as well. And so we really did utilize that tremendously throughout our whole facility, almost to where it became a crutch. It became the thing that was kind of holding up some of our beds because we only had so much capacity to do it. We did expand some of that capacity. I think it was extremely helpful. And I think it was also something just for the staff, especially, in that initial push of COVID, when we really didn't know, is this aerosolized only? Is it airborne? Is it how much do we have to worry about fomite transmission? There were so many unknowns that I think it was one more step that allowed us to give, our employees just a little bit more of a breather to say, look, we've done everything possible that we can to this room or this area to keep you guys safe. And so I think that was really important as well.
Thank you for that. Thank you both. I think we might have time for one more question before we wrap up our program for the day. And there's a question around, it looks like you guys were doing walk-ins, Dr. Elder, and now, or maybe you were doing appointments and now doing walk-ins, or the question is around appointments versus walk-ins. Any thoughts on that?
Yeah, so, we initially started with appointments, and that was done specifically, again, to keep people distance. We didn't want large groups of people at one time, just kind of, overwhelming, what we were trying to do. We had gone through a lot of COVID testing in the community, and we learned that really registration was the bottleneck. No matter how many people you had performing registration, it took time to do it. The test itself is very quick. It's a swab, so you get people in and out. The vaccine itself is quick. You give them an injection, you move them on. But really that registration piece took the most amount of time. And so we set up, it was new for our healthcare system, an online scheduling system where they could go online, get themselves scheduled. We had a call center that was set up as well. And so we initially started that just to keep people, separated. And then since the numbers have, gone down and the demand isn't as high, we have allowed for walk-ins as well. That's actually worked out very good for us. We have on-site registration as well that's socially distanced, and we keep the lines, separate and spaced out. And so we have now moved to also walk-ups.
Well, thank you for that, Dr. Elder. Again, thank you to both of our speakers. As we close our program today, I want to say thank you to our attendees for joining us. And I want to remind you that this is, again, webinar 1 in a 3-part series. Please register for part 2 and part 3. Part 2 will be on May 12th, and we'll do a case study on pod-based planning, mass vaccination, and infection control. And May 19th will be all about applying science-driven infection control operations to large-scale mass vaccination sites. I'd also like to invite you all to register and join us on May 19th for the third and final Emerging Lessons COVID Response Action Toward Equity event hosted by NNPHI. And May 19th from 1 to 5 p.m. There's information there. On behalf of all of us working on Project First Line and those of us at the National Network for Public Health Institutes, thank you so much for joining us.